Hey everyone, welcome to Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am anesthesia and critical care at Hopkins. I'm an active volunteer at Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors in the medical director's office at Baltimore County. On behalf of Andy Pollack in the medical director's office, on behalf of the EMS office, Director or Chief Shedding, Captain Stewart, Captain Fitzpatrick, thank you for what you guys do every day. Thanks for your dedication to lifelong learning. Big shout out to Ashley Brooks. Ashley is one of our volunteers at Pikesville Volunteer Fire Company in Baltimore County. Ashley is helping us run the live stream. Ashley is the one who's going to send out in the chat at some point a link. If you click on the link and fill in some information, you can get your MIM CEUs. So if you want your MIM CEUs, keep an eye out on the chat when Ashley sends out a link. We'll also make sure to announce it as well. Tonight, we're incredibly excited to have with us Dr. Elizabeth Dovec. Dr. Dovec is a CEO and co-founder and co-creator of New Try Health, a trusted, standardized, state-of-the-art virtual preoperative education system to prepare patients for bariatric surgery. She is a bariatric surgeon, bariatrician, and medical director at GBMC Comprehensive Obesity Management Program since 2013, after completing fellowship training with Vanderbilt University's Advanced Laparoscopic and Bariatric Surgery Program. Through novel approaches focusing on the patient experience and sustainable results, she leads one of the busiest programs in the nation. A board-certified general surgeon and fellow of the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, and a diplomat of the American Board of Medicine, she is passionate about diminishing the staggering obesity epidemic. Dr. Dovec, thank you for being with us. Thanks for what you do. Thanks for spending time and sharing.
Thank you so much, Sean. I am so excited for this opportunity. I see some friends on the call today, and that is exciting to me. You know who you are. I see quite a few, and hopefully at the end we can make this engaging. So I know how these Zooms go. They can be boring. They can be like, oh gosh, another Zoom gloom PowerPoint presentation. So I want to make this different. I want you guys to really get some powerful knowledge and information out of this. And I want to tell you a little bit more about the world of bariatric surgery. It is an exciting specialty. To me, it's my life's work, and I'm totally passionate about it. And I hope that you will see that and see some of the incredible results. And I just want you to know a little bit about what the patient goes through to get the surgery, a little bit about the surgical details, and then after surgery, when do we want to involve you? Hopefully never, but if we have to, how do we make sure that you help to triage appropriately? What are the common complications or issues that might arise? Why would a patient need to go back to the hospital that they had their surgery at? So I'm going to tell you a lot of different things, and we'll have plenty of time at the end to, again, interact with each other, share our stories, our experiences, our questions, and hopefully come out of this even stronger in our ability to care for this very amazing patient population. So, obesity, let me tell you, nobody wants to be obese. Okay, it might be a newsflash to some of you. You might not understand it if you haven't struggled, but for most of us out there, there has come a point in our lives where we've realized, my God, my clothes aren't fitting, or oh my goodness, I just got a new diagnosis of diabetes, or oh geez, I'm not living my life. Like if you were to go to Disney World, would you be able to fit on the rides? Would the patients be able to fit comfortably on an airplane seat? Would they be able to walk the 20,000 steps? Do they feel cute? Do they want their picture taken? There's a lot of things that go through your mind. And the thing is, every patient that I see, every patient, 100% has tried diets and exercise and probably medications, and they've tried everything that they can to avoid me. No one is particularly thrilled to need my skill set, and it takes a lot to get to that moment, that breaking point where people are like, you know what? I can't do it anymore, and I need this. And I am very, very humbled by all of my patients, and I love to learn about why they're there. Why do you want that? Why do you feel like you need bariatric surgery? So our patients have gone through a lot mentally, and they fight hard for it. Before surgery, patients have to do a lot. They have to be educated. They go through a lot of nutritional education, exercise, and they understand all of the mindset changes that need to go into this. How do you change your habits? How do you get support? How do you make sure that you don't just lose weight in the short term. How do you keep it off? So there's a lot of things that happen beforehand. And then finally, the patient decides to have bariatric surgery. And again, that's not an easy decision. A lot of people do feel like they're a failure or that they feel a little bit ashamed, but I tell them you should feel so proud that you've decided to take this step to better your health. So know that these people are fighting hard. Please always come at them from a place, but nothing but love and respect. I think that you always do when you treat your patients. I'm sure you do, but just know that it's really, really hard. And then they're there and they want to get the most out of it. So with that, I'm going to share my screen and I'm just going to show you a few slides here. And I'm going to show you first a little video clip. Here we go. To show you a little bit more about the results. And keep your eyes open because I think somebody on this call might be featured in this video. Let's check it out.
I kind of disappeared from life. My breaking point was when I woke up one day and I didn't recognize the person I had become.
Like I never left, another sprint.
But I always felt like I was the biggest person in the room, but I was invisible.
Chasing dreams, but I never slept. I got a new attitude and a lease on life is a piece of mind.
Surgery, I was basically sitting on my couch, either trying to grow to it or waiting to die.
Because of the surgery, we now are expecting our first child. It makes me feel extremely excited and happy just to be able to watch God's miracle.
It's time that somebody mentions your name. So when I leave here on this earth, did I take
weighed in at 242 pounds. I knew at that moment that would be the last time I would weigh that much.
searching for euphoria, judging through.
I was looking in the mirror one day and I just started crying. I just told myself I couldn't do it anymore.
My mama told me never bow your head.
Could have prepared me for the devastation and embarrassment that I saw in those pictures.
I was diagnosed as medically obese at 8 years old, and at 38, I got my life back.
Constantly having somebody say that you could possibly die, it was like I was taking myself from my kids.
Very lethargic, never really want to participate in any sports or really want to do too much that was getting me out of my comfort zone.
I am 129 pounds, and I am damn proud of myself.
Things are just things, they don't make you who you are. Can't pack up all you.
I tell everyone, if you're even remotely thinking about doing it, do it.
Porch my family's glasses to the stars. My grandma smiling down on me like, that boy got bars.
Okay. So let's talk about these surgeries. So we perform two main types of bariatric surgery. So the first one I'm going to go over is called the sleeve. It's also known as the vertical sleeve gastrectomy. So if you're ever on Instagram or looking up hashtags, a lot of people know it as the VSG, or it's a sleeve gastrectomy. With these operations, we do them typically minimally invasive. So I'd say 100% of the time, I do it through little tiny incisions. So we put incisions near the belly button, and then we put two little pinky-sized incisions, less than 5 millimeters out to the side. With the stomach is about the size of a football. And then we take it down with the sleeve to about the size of a garden hose. So the way I do this is I use a sizing tube so that I don't make this patient's new stomach too big, but I also don't want to make it too tight or too narrowed. So I put the sizing tube in, and then I use a device that staples, seals, and separates off about 80% of the stomach. The way I do that is by pulling it out to an incision to the right of the belly button, and I pull it out. All right, brace yourselves. Here it is. This is the 80% of the stomach that I remove. So that all that you're left with is this darker pink stomach here. Now, this is where it's very important that you guys understand some of the things that can go wrong with these operations. So along this is a long staple line. These staples always stay inside of the patients. They are made of titanium. It's the most biocompatible material. They can safely go through MRI detectors or MRI machines or metal detectors. They're very, very small. They get incorporated into the tissue, but they're always there. Now, we want to make certain that this new staple line along the stomach is perfect. I want to make certain it's airtight, that there's no holes and there's no leaks. So one thing could be a leak. So a leak is when there may be a little hole somewhere along here so that when you ingest food, it goes into your mouth, into the esophagus, in through the GE junction, the gastroesophageal junction, and then into the stomach, the new smaller sleeve stomach. Well, what can happen is if there's a leak, things that are dirty, food will ultimately become stool, we know this, will potentially leak out through the hole, and then that can cause a focal abscess. If it's left untreated, it can even lead to sepsis, multi-system organ failure, and even death. So if a patient is just looking toxic, they're sweaty, they're tachycardic, tachycardia is the number one symptom that something's going wrong. Hyperglycemia is number 2. So it's the stress response that happens. And in our patient population, sometimes the physical examination is unreliable. With morbidly obese, they might not have peritoneal signs, meaning rebound tenderness or involuntary guarding. They may not have that, but tachycardia is not normal in our patients. It could be something as simple as dehydration, but it might also be something like a leak, or another even earlier potential complication is a bleed. Bleeding can happen anywhere along the staple line. With the sleeve, it can happen both inside the lumen, so it could be inside the GI tract there. So patients may vomit blood or pass bright red blood per rectum or have more dark or tarry stools. They could also be tachycardic because they're just dehydrated. So sometimes these surgeries cause patients to be very nauseated. You might have seen this before. Patients don't keep up with their fluid intake. We want them to drink at least an ounce over 10 minutes. If they start to fall behind, it can be very difficult to get caught back up. So the best thing to do in our patients, typically they can handle it from their heart standpoint, is to just start a big IV and give them 2 liters right off. And that should normally help to perk them up. If they're nauseous, we always do Zofran ODT, dissolvable. They can also have scopolamine patches. You can also prescribe something like Reglan or promethazine or Phenergan. So all of our patients do have a prescription for Phenergan. It does make them a little bit drowsy, however. So the sleeve operation takes me about 20 minutes to perform. I am able to do the patients in the operating room for about 45 minutes in total. That includes everything from coming into the OR, laying on the bed, getting intubated, having the operation, waking up, and leaving. That's all about 45 minutes in total. We talk about weight loss in terms of excess body weight. So if a patient should weigh 150, but they weigh 250, that means they have 100 pounds of excess weight. With the sleeve, on average, our patients will lose about 60 to 70% of their excess body weight. Now, one of the issues with the sleeve is they could get some acid reflux because at the end of our stomachs is the pylorus. With the smaller stomach pouch, sometimes when you eat, that will close. And unfortunately, sometimes that will cause things to be driven back up. So it creates a high pressure system that will cause things to go back up and into the esophagus. So sometimes they can have a little bit of acid reflux with the sleeve as well, which, as you know, acid reflux can give you a lot of chest pain, and it could be misinterpreted that, oh my goodness, I'm going to call 911 because I think I'm having a heart attack, or I think I'm having a pulmonary embolism, like I'm having so much chest pain, and it might be reflux. So if you have omeprazole or something like that, have them try to take that Tums, something to potentially alleviate their symptoms if it is secondary to reflux. Now, the gastric bypass, this is another very popular operation. I actually do more gastric bypasses than sleeves. This is also minimally invasive. It is a misconception that these operations are more invasive. Unfortunately, the gastric bypass got a very bad rap when a lot of people out in the community just think that it's only for people that would be on my 600-pound life. That is not the case at all. In fact, the people that qualify for surgery are having a BMI greater than 35 with comorbidities such as diabetes or sleep apnea or high blood pressure or high cholesterol, or if a patient's BMI is greater than 40, they qualify based on their BMI alone. With the gastric bypass, the stomach will go from the size of a football down to the size of a thumb. The new stomach will only be 5% of the size that it was. And it's called a gastric, meaning stomach bypass, because 95% of the stomach is still inside of the patient, but it is now bypassed from seeing and storing food. So what happens is patients will eat food, goes in the mouth, goes in the esophagus, goes into the little thumb-sized pouch, and then goes directly into the small intestine. This portion of the small intestine is called the roux limb, and this connection here is called the gastrojejunectomy, or GJ anastomosis. So we'll nickname this the GJ, gastric pouch to jejunum, which is the second portion of the small intestine. So this is the GJ anastomosis. Now, this 95% of the stomach is still making stomach or digestive juices, all of its enzymes. The liver is still making bile, which may come in to the small intestine. The pancreas is still making its enzymes. So all of those digestive juices and things are going downstream just like they always did. So they go in through the 95% of the stomach that's bypassed, through the pylorus, into the duodenum, and then into the first 70 centimeters of jejunum. So this connection here, where the food will meet up with the digestive juices, is a connection of jejunum to jejunum, and it's called the jejunojejunectomy, or the JJ anastomosis. So at the Y connection here, this is why it's called a roux, which is someone's last name, and Y is because at the Y is where the digestive juices will mix up with food for the first time. The gastric bypass takes me about 1 hour to perform. The patient will be back in the operating room for about an hour and a half. Just like with the sleeve, I do not use drains. I do not use Foley catheters. I want patients moving right after surgery. And then once they get to the recovery room, with both the sleeve and the gastric bypass, if a patient is hemodynamically stable, if they're able to drink at least an ounce over 10 minutes for over 30 minutes, so at least 3 ounces of fluid intake, PO, and they're able to urinate, so walk, pee, and drink, they are able to go home directly from the recovery room. So since COVID, I have been operating a lot at GBMC and sending patients home same day. And I also operate at a surgery center in Hunt Valley, Maryland. So I have done to date about 650 outpatient bariatric surgeries, and we're one of the top centers in the country for that. But that means patients are now home the day of their operations, which means you may be getting called if patients are concerned. Again, chest pain, I just don't feel right. Maybe a loved one witnesses them getting orthostatic. Maybe they had a bleed and they get orthostatic hypotension. You might get called. So we're going to talk now about that some more. So I'm going to stop sharing my screen, and I'm going to tell you a little bit more details about the things that you might get called on. So again, I do sleeves, I do gastric bypasses, and I do revisional surgeries. So we no longer do the lap band. So that's a thing of the past, but I do a lot of removals of lap bands and conversions to sleeves or gastric bypasses. So those are the procedures that can be performed. Now, I love this. We're starting to get some questions in the chat. So if you have questions, you can write them to everyone, or you can directly send it to me and I will get it. So I have a question here, and then we'll talk some more. And so you can start adding them. Ask me anything you want to know, no judgment. And I want you to feel, again, like you can really take care of this patient population. So the first question is, what happens to the extra skin? So that's a great question. I get asked that every day from patients because people are scared, like, well, what am I going to look like? What is this going to be like? Like, I don't want the loose skin aspect to be worse than if I was overweight. So what happens is, it just depends. There's a lot of variability in the elasticity properties to the skin. So some people are very lucky, and those tend to be African Americans. Black patients have more elasticity to their skin, so they tend to boing back a little bit better. The younger you are, the more elasticity. Think about wrinkling. Wrinkling happens the older you get. Babies don't wrinkle. So the younger you are, the more elasticity you have. And then finally, men. Of course, men always have it easier. No, I'm kidding. But men are able to, they tend to have more elasticity to their skin. So young Black men can even have six packs after these operations. And you may never know that a patient had this operation. So let's talk a little bit more about the acute potential issues. So let's start off with something really scary. Let's start off with a patient is called, they're collapsing, they're not doing well, they're unresponsive. I've had a patient who this has happened to. The loved one calls 911. They have a history of obstructive sleep apnea. That's something you need to be very concerned about because airways can be a difficult issue. As you guys all know, the extra tissue around the neck, they can be hard airways to potentially need to intubate. If a patient has, so just to back it up, we at our practice, we make sure that we aggressively screen for obstructive sleep apnea. So we use something called the Epworth Sleepiness Scale. So it's a subjective measure of how likely are you to fall asleep in certain situations. And if their number is greater than 10, we require that they have a home sleep study. So with a home sleep study, if they have mild sleep apnea, we do not require the patient to demonstrate CPAP compliance. If they have moderate or severe sleep apnea, we do require that a patient have CPAP compliance and they demonstrate that. And we define that as wearing their CPAP machines for greater than 4 hours, greater than 50% of the time. I know that there has been a thought in the past that an acute post-op anastomosis, a new connection, especially with the gastrojejunostomy, the upper connection, that there's been some worry that, oh, well, we don't want to put their CPAP machines on or BiPAP because we don't want to force the air there. We don't want to disrupt the anastomotics, the staple line. We don't want to do that. We have found that we need patients to please wear their CPAP machines if they feel like they're going to even take a nap or sleep at night. That CPAP machine is literally the thing that can save their life as long as they have that on. So when you go into the houses, make sure that you ask, do you have sleep apnea? If they're having any issue, make sure you put that machine on them so that they don't get any respiratory acidosis from retaining CO2, that they're blowing it off. So that's a big consideration, is retaining CO2 if they're not breathing, especially if they take a phenergan. Like I said, we give the nausea med that can cause some respiratory depression because they're tired. And then of course, narcotics. Narcotics is a big deal. So if you're worried, you guys know this is like, I know top of mind for you, but always think about, okay, are they a little bit lethargic? They seem a little bit out of it. Let's just give them Narcan. Just give them Narcan, just go for it. Just so you know, we do try to minimize narcotics. We do early or enhanced recovery after surgeries called ERAS protocols. We make sure that we look to see, all right, how do we prevent narcotic use as much as possible. I give my patients a prescription for Dilaudid 2 milligrams, and I give them just 5 total tablets, and I tell them to try not to even use the 5 if they can help it. Patients will typically help them to fall asleep, and that's when they take it. But again, I tell them, make certain that you're wearing your CPAP machines if you're feeling like you're going to fall asleep. And I tell the family members that too. Make sure your loved one has the CPAP machine on. Other things you could get there, and they could be having chest pain that, of course, is your typical. It could be an MI after surgery. It could be a pulmonary embolism. I do send patients home. I tell them you need to walk. You must walk at least once an hour for 5 minutes every time you're awake. But sometimes they might have a hypercoagulable state. They might be more sedentary. They didn't move around, what have you. So you always have to have a PE on the top of your mind, especially if they're tachycardic and they're complaining of back pain. That's almost always a PE until proven otherwise. Also, they could be, again, bleeding is one of the earlier ones. Leaking typically does not show up until later. If it is going to show up, it typically starts to happen at 5 to 7 days post-op, usually. But bleeding is something that could happen early. They would have tachycardia. If they're really bleeding briskly, they could get hypotensive. So you want to resuscitate the patients with volume. Start the IVs, really pound them with at least 2 liters, tank them up. You don't have to worry so much about cardiac or overflowing and those sorts of considerations with our patients. They can handle it. Give them the fluids. Go for it really, really hardcore. And then they could also have a DVT if they're complaining of severe leg pain. They could just be, again, dehydrated. They could just be nauseous. That's very common. They might be vomiting. So those are the common things after surgery. Now, I have another question in the group chat, and we were asked, is the gastric bypass reversible? And under what conditions would that be done? Trying to understand the reason for the bypass versus the sleeve. awesome, awesome questions. So first, I'm going to tell you about how I help a patient guide them towards which surgery that they want. I really want my patients to have ownership in that decision. I want them to do their homework. I want them to feel like, yep, I know my body, I know myself, I know my history, and I feel so comfortable going with this particular procedure. So here are the 3 things I tell people to pick one over the other. Number 1, if they're a diabetic, especially if they are a long-term diabetic, if they're on insulin, I tell them to go with the gastric bypass because I'm not sure if you know this, but instantaneously after surgery, and we don't know why this happens, believe it or not, diabetic patients, type 2 diabetic patients who are not requiring insulin, but type 2 diabetic patients actually leave the hospital right from the recovery room on none other type 2 diabetes medications. So that's something else to consider that you might get called on. Once in a while, we'll have a type 1 diabetic patient and they're just not used to their blood sugar kind of being out of whack that first day with that, again, that stress, that inflammatory response. So I've had a couple of patients that came back in with DKA. So you have to be careful of that. Always, I mean, just go through your usual algorithms for things that could be wrong, check the blood sugar, that sort of thing. Especially when patients are trying to figure it out. They might be hypoglycemic, low blood sugar, if they maybe were taking too much insulin because they didn't realize how much their insulin sensitivity improves so quickly after surgery. We really try to impress that on patients, but that's something to think about. You might need to give them D5 or a glucose tab or something like that. Now, a second reason to pick the bypass over the sleeve is if you have more weight to lose. So with the sleeve, I mentioned that patients will lose around 60 to 70% of their excess body weight on average. And with the gastric bypass, they'll lose about 80 to 85% of their excess body weight on average. So patients typically lose more. And so if the patient's BMI is over 45, and if you're not sure what your BMI is, you can always just Google BMI calculator. It's a ratio of their weight in kilograms to their height in meters squared, and you can determine your BMI. So if their BMI is over 45, I do push patients more towards the bypass. Again, better weight loss and potentially better long-term weight loss, which is also behind something called dumping syndrome. I like dumping because it happens when you binge on a huge amount of sugar. So for example, if you binge, if you eat a huge thing of ice cream, you might pay for it because your body will be like, oh my God, like, what are you doing? Because so much insulin will come on the scene that you'll get hypoglycemic, you'll feel sweaty, lightheaded, weak, you know, the signs of hypoglycemia. And patients feel like they're going to pass out. They don't feel well at all. And it's almost like, don't do that again. So I think it's harder to get off track with that. Third and finally is if a patient has bad acid reflux, GERD, heartburn, if they have a known hiatal hernia, which is when the stomach, which should be in the abdomen, has herniated above the diaphragm and is now in the chest, I would say don't go with the sleeve because again, the sleeve, sure, by losing weight, your acid reflux might get better, but the sleeve could also make it a little bit worse. And you might even need to have a revision of a sleeve to a gastric bypass. And that happens about 5% of the time. So it's 1 in 20, it's not arbitrary. It might need a surgical revision. So to review, if you're a diabetic, if a patient has more weight to lose, BMI greater than 45, or if a patient has acid reflux or a hiatal hernia, I push them more towards the gastric bypass. Now, that is not to say that if you have those conditions that you couldn't still have a sleeve and totally thrive and kill it with your weight loss and do amazing. So I let people think about it. Some people just cannot stand the idea of the sleeve with the stomach being removed or the bypass and the rerouting. And so I let patients really pick that on their decisions. Now, the other question was trying to understand why would a gastric bypass be reversible? And the answer is yes, it is. So with the sleeve, I remove 80%. Once that's gone, it's out of there. But with the bypass, the 95% that's in there, it stays in there. Now, in theory, it can be put back together. I have never had to reverse a gastric bypass in my career. So there's no complication that would cause you to need it to be reversed. From my standpoint, I have seen it be reversed once in somebody who became addicted to narcotics, and it was a whole thing, and they just wanted to take the bypass out of the equation because they said that they had chronic pain from it, and it was just he was just going down a dark road with his narcotic addiction. So they took the bypass out of the equation and they reversed it. So yes, it can be done. I don't do them, but Mike Schweitzer, awesome bariatric surgeon, superb. He's at Hopkins. He's the director at Hopkins Bariatric Program, and he does it. And I just want to shout out to all of my bariatric surgeon colleagues. I think that we are in an amazing area in the United States. We're a super saturated market. There's actually 10 programs within 10 miles of GBMC. So I'm at GBMC, but there's programs at University of Maryland. That's Mark Kligman. There is ones at Northwest, LifeBridge, MedStar, Hopkins, St. Agnes has one, that's Averbach and Hamdallah, and then Mercy has one now too. So there's a lot of programs because we need to help a lot of people, and bariatric surgery saves lives. It's the most effective tool that exists to lose weight and to keep it off. So more questions. What about patients with PCOS and have insulin resistance? Awesome question too. So with PCOS and insulin resistance, I don't know if you know, but of all the patients in the United States that have weight loss surgery, over 85% of them are females, and they are usually of childbearing age. So our demographic is typically 25 to 45-year-old females. And a lot of my ladies are coming in because they are struggling with PCOS, hormonal imbalances, and maybe infertility. So I think the best to improve insulin resistance is the gastric bypass. However, the sleeve has been shown in studies that after a year to have very comparable results. So fertility rates, PCOS improvement, getting more regular with the periods, all of that are improved with the sleeve and the gastric bypass. So when people say, well, when should I have surgery, before or after I get pregnant? Absolutely have weight loss surgery before you get pregnant. It will make your pregnancy safer. It will make you more fertile. It will make the baby safer and more likely to be born at full term. So it's just the best thing you can do as for the mother and for the baby and for the health of everyone involved. Okay, I have one here. I'm wondering if your dad is Dr. Jonathan Hamburger. Please enter that into the chat. I'm curious. He's an anesthesiologist at GBMC, and I know that he has a son that does the EMS stuff. So regarding GERD, is there a change in stomach pH post-procedure? And is there an increased, decreased risk of Barrett's or esophageal dysplasia long-term? This has to be Jonathan Hamburger's son. Oh my God, this is awesome. Such an awesome question. I love working with your dad, especially at the surgery center. So tell him Betsy said hi. All right. So great questions. So the one about the pH post-procedure is no. There's no change in the pH of the stomach post-procedure, but this is such a thoughtful question. I have never been asked this. So with the gastric pouch, it is now, with the gastric bypass, the gastric pouch is now right up against the small intestine. So the gastrojejunostomy is a new connection. The stomach, which is acidic, is now next to the intestine, which is basic. These two things are not usually up against each other. So what happens sometimes is we ask patients to please take omeprazole or some sort of proton pump inhibitor for the first 90 days after surgery, because we want to prevent something called a marginal ulceration from occurring, because it can change that pH is now different in the jejunal side. And so that can lead to ulceration. So when patients get ulcers, it's not happening on the stomach side, it's happening on the rulum side, the jejunal side, and that's called a marginal ulceration. Those are typically found in patients who smoke. So if you smoke after a gastric bypass, some of you know this, it can lead to some really devastating things, not just ulcer, it hurts like hell. It's like the equivalent of you biting the inside of your mouth. You know how bad that hurts your mouth? Well, imagine it every time food goes past you right here. But it can even lead to perforation. So if someone comes in like out of the blue, maybe a smoker, maybe does excessive alcohol, maybe does a ton of anti-inflammatory meds, and they come in and they're like, oh my God, I feel like someone is stabbing me in the abdomen. Guarantee they have free air, guarantee that they're going to need an operation. Free air is not compatible with life. You need to go in and you need to fix the perf. We do something called a gram patch. I take Omentum, which is fat, the fatty apron that covers the intestine. We fix the hole, do a leak test, and then patch it with Omentum as well. Now, Barrett's esophagus is a condition where the lining of the esophagus becomes metaplastic. It changes, and it's actually a precancerous condition. So I will not do a sleeve in a patient with Barrett's. because of the propensity for that to cause more acid there, that could potentially, in theory, take them from precancer to full-blown esophageal cancer. So Barrett's has been proven in studies to be treated by a gastric bypass, because with the bypass, you're bypassing the pylorus. So that means food and drink can go straight into the esophagus, the stomach pouch, and into the small intestine. And there's nothing that's holding it up and causing it to drive back. And that actually will take the pressure off of the esophagus, the lower esophageal area, which is where the Barrett's would be. And it actually has been shown to help to heal the Barrett's on all the routine surveillance afterwards. So the gastric bypass is the standard of care in treatment of a morbidly obese patient who has the Barrett's. I'm wondering what would happen if someone had a small portion of a food like pizza or mac and cheese after some time recovering from surgery. Would they have a similar experience like you described with the dumping syndrome? So, oh, I see also that you're not Jonathan Hamburger's son. Okay, got it. So the question is about food. All right, so this is a good question. It brings up another point. After these operations, these patients are supposed to be following a very strict diet to let everything heal. When I do my gastrojejunostomy, when I'm doing a gastric bypass, I am hand sewing. I'm hand sewing that anastomosis closed. I do a leak test to make sure it's a 360-degree airtight seal. But the thing with that is it's a suture. I mean, it's a 2-0 vicryl. It's a sorbable suture. So I want to make sure that they follow a diet progression. So this is what the patients are told to do. 2 days and 2 days only before surgery, they are on sugar-free clear liquids only. So they're doing things like water, Crystal Light, Powerade Zero. They can also do broth. They can do sugar-free Jello, sugar-free popsicles. They can do some kind of clear liquid protein that's not a shake, like Isopure, Protein 2.0, Premier Clear, Atkins Clear. Day of surgery, nothing to eat or drink the day of surgery. Have surgery, we'll say Monday, they go home on Monday. Once they get home on Monday afternoon, they can immediately do full liquids. Full liquids, they'll stay on for 1 week. Full liquids are things like the protein shakes, milk, powders, fine. When they're picking a protein shake, they want the first ingredient to be whey protein isolate. They stay on that for 1 week. Week number 2, they're on pureed foods, which is like a smooth consistency, like a baby food consistency. We tell them if you don't like a stage, go backwards. You can go back to full liquids, but don't go forwards. And then finally, the last 2 weeks, weeks 3 and 4, they are going to be on soft foods. So no tough meats, no raw vegetables. People crave salads after this, and it's very frustrating when they if they eat broccoli. Like, I just thought it was healthy and it was good because the broccoli, remember, these are small connections. I've had patients who've had broccoli stuck at that Y connection downstream before, and it results in a temporary obstruction. That's another thing. If patients are really vomiting, they might have an obstruction at the lower connection. The JJ is just like plumbing that gets clogged. Everything above it dilates, everything below it's decompressed. So it can cause a lot of abdominal pain, nausea, vomiting, and a lack of passing gas as well is a typical a small bowel obstruction type of a scene. So after 4 weeks, let's say this patient that you're describing is out of the blue, and now they are on regular food. The thing is, you can still eat things. You want to do things that are lower in carb. We tell patients to limit their net carbs less than 50 grams per day. If they were to happen to eat a little bit of pizza or mac and cheese, it's not going to kill them. And chances are, if it's a little bit, a bite here and there, they're not going to get dumping or anything like that. If they binge on a huge amount of it, again, they could potentially have that. So dumping is variable in every person. It's more common with the gastric bypass and with the sleeve. But sometimes if you really avoid carbs and you're in a more ketotic state, when you do eat something, you can get sick. Like whenever I'm like really I'm really strict on my own carbs, I know that I feel a little bit nauseous if why did I eat that pizza? Like, why did I eat that thing at a cake? I won't even do it anymore. Like, it's just, I don't know. It's not worth it. All right. More questions. I love it. How soon after getting the surgery could a patient with PCOS get pregnant? Fabulous question. We recommend that they wait at least a year. And there's a lot of studies that show that it's just a lot better for the patient, for the mother to get down to her goal weight. Remember also, you have to take a multivitamin that contains iron, folic acid, and thiamine, that's vitamin B1, or and calcium citrate for life after these operations. So we want to make sure that before there's a malabsorptive type procedure or a nutritional deficiencies propensity for that, that the mother is in a routine and has her tank on full before the baby starts to suck that out of them. Now, some mothers are older, and so we might want to or need to get them started earlier if they have advanced maternal age, for example. So there's considerations. Now, I've had patients that literally get pregnant the first week. Ugh, we have that a fair amount, more than you would think. And if that happens, it's fine. I mean, there's no need to terminate the pregnancy. They can still have a very healthy pregnancy for both. It's just not as ideal for the reasons I already described. I just want to say I have followed you on Instagram for a while, and I will be getting a sleeve maybe in 4 months. Thank you for the information. That is amazing. I wish you the best of luck. I know it's not an easy decision, but you're going to do absolutely fantastic and be so glad for it. And there's some patients on this call that had surgery and they might want to hook up with you. So that's great. I have another one here that says dumping syndrome is more for the excess sugar. Honestly, after my sleeve, the pizza and the mac and cheese just lead to guilty feelings. Amen. Couldn't agree more. Oh, here we go. We're finding out who is Hamburger's son. This is all very good. Whey protein is so inflammatory for a lot of people. Why not use pea protein? So it's a good question. The whey protein isolate is the most, there's been things that show that it's the most maximally absorbed. And because patients can't get in as much in the beginning, we want them to try to do that. Now, if they go for pea protein, other types, concentrates, blends, muscle milk is even not the first ingredient, isn't whey protein isolate. It's totally fine. The thing is, at about months 3 to about months 9 months post-op, patients can experience some hair loss and hair thinning if they're not getting adequate amounts of protein. I do stress to patients very strongly that patients are doing as much protein in food as they can. So the way to eat after these surgeries, it's not several small meals a day. It is breakfast, lunch, and dinner. Don't skip meals. Do not skip meals even if you're not hungry for breakfast. Do you know that almost all of my patients eat too little instead of too much? It's not that they're just all sitting around eating pizza after pizza each day. It's that they wake up, they don't eat breakfast. I'm busy, I'm running around. Maybe you feel like it's you, like you're in your trucks, you're like doing your thing, you're saving lives. I mean, you have big stuff. And unfortunately, you're not taking care of yourself. You're not eating lunch. Next thing you know is dinner, you're starving, you're on the road, screw it, I'm gonna go through the drive-through. Or I'm at home, I just need something. And you wanna go for a quick energy source, which is gonna be high in carbs, it's gonna be high in glucose, and you're gonna crave, let me eat this bag of chips or eat this candy bar. Just give me a quick energy source so I can feel better. And it's basic survival. So always eat 3 meals a day, whether you have weight loss surgery or not, just a fun thing. So I'm not opposed to other types of protein, Sean, but just something to think about. Oh, and he's online tonight. Awesome. Is the Gatorade with protein okay to have to take in, or is the protein powder better? I think the Gatorade with protein is great. In fact, there's other types of ways of getting in protein. We have all kinds of little tips and tricks and ideas. We have a secret support group on Facebook, and it's called you wouldn't be able to find it. You have to friend me, and then I have to add you to it. Or you could friend some other patients here that are in it, and you have to be friends with somebody they can add you to the group. And it's great because we give each other tips, such as you can use something like unflavored Undri powder. You can sprinkle that on things. You can add things to your coffee. There's like so many different ways to get more protein, because our goal is for you to consume at least 70 to 90 grams of protein per day, or an average of around 25 to 30 grams per meal. It's harder than you think. You really have to think protein all the time. Every snack you eat, anything you do, can I get protein in here, so that it's not an empty type of food. So Dr. Chris Yu at Franklin Square is doing a patient surgery. He's awesome. Awesome. Tell him I said hello as well. So you're in great hands and you're going to do fabulous. I hope you're feeling good about your operation coming up. I often eat once or twice a day, sometimes hardly any water, something that I'm working on. That's another huge thing. Listen, you guys need to consume. We all do. We're humans. We all need at least 2 of these. This is a liter. You need at least 2 liters of sugar-free fluids a day. The fastest way to gain weight is to drink your sugars. You got to get rid of the sodas. It is a poison, is the most toxic thing you could do for your body. Fruit juices, I know they look good. Vitamin C, orange juice, I know, but like don't do it. And then also sports drinks. You think regular Gatorade is fine. Like I need the energy, I need the electrolytes. We tell ourselves a lot. We really believe our own stuff sometimes, our own BS, but truthfully, you got to keep with the sugar-free clear liquids. And let's see here. Any thoughts on a vegetarian or veganism after surgery? It is honestly harder. I think it's a much harder way to get protein in, but we have an amazing dietitian at our program. Her name is Jana Wolf. You can even email her. Her email is jwolf with 2 F's, JWOLFF at gbmc.org. And she gets this question a lot, and she even has some great handouts and educational materials for anyone that is interested about how you can get enough protein and stay healthy and hitting your targets and minimizing carbs while maintaining a vegetarian or vegan lifestyle. It's not for me, but I know a lot of people are into it for a variety of reasons. So what other questions do you guys have about the patients, why you would be involved acutely, complications, long-term, what it's like? Let's see here. Jana is awesome. She is awesome. Awesome. All right.
Thank you so much.
Thank you, Sean. This was super cool. I love the questions. They were so good. Oh, I may have missed it, but is there a decent percentage of people who come off diabetes medications? Are you ready for it? This is such a good question. Type 2 diabetics that come off their meds, 98%.
Wow.
I get to cure diabetes. I get to help women get pregnant. I have a pretty darn cool job. I don't know why everybody doesn't want to be a bariatric surgeon, but I kind of love it. When was this surgery first created? So gastric bypass has been around since the 1960s. 1960s, it became popular more in the 80s and 90s. It was still an open procedure. And then the early 2000s, it went from open to laparoscopic, and that changed the game. When we changed our skill set from doing things that are 3-dimensional to 2-dimensional, because the screens, it is a 2-dimensional, so you have to train your brain to think different. Like if I want to grab here, I want to make sure that I can do it. There were some complications in the early 2000s, but now every day we get better, more efficient, more proficient at it, and the complication rate, death rates, and all of that sort of thing are negligent at this point, which is fabulous. Here we have a couple more questions, and let's see here. All right, we have a patient on the line who really went through the ringer. He is one of my favorite patients of all time. His name is Jerry. He's going to unmute himself, and he's going to tell you a little bit about his before weight, his current weight, what he went through, how he fought like hell for his life, and how he's a better man for it. Jerry, let's hear it.
Hey everyone, how are you? I had surgery back in September.
Oh, we could hear you. Now, there you go.
Okay, now you go. I had surgery back in September. I chose to get the bypass done. I was about 315 pounds, and I ended up with an abscess, and the abscess popped. I don't remember a whole lot. I ended up going septic. I called 911, and everything I was having at the time, the fever, the chills, the whatever had passed, so I let it go. And probably about 2 hours later, it all came back with pain. So I called 911 again, ended up at the hospital, ended up on FaceTime with Betsy, and ended up in surgery again. At some point, I was put into a coma. I had a bunch of complications with the infection, of course, among other things that she could probably touch base with. I'm currently 8 months out now and down to 186 pounds and probably in the best shape of my life. She truly saved every bit of my life that I had left.
Jerry. So, was it worth it?
Completely worth it.
Awesome.
Completely. It was hell and back, but it was worth it in the end.
Totally. Yeah, Jerry had he had a lot of pneumonia, respiratory type situation, and he had some great support, great friends. You guys all know Dr. Wittberg as well. He had an amazing ICU intensivist, and look at him. He's in fighting shape. You guys should see his transformation. It's one of the best, one of the best. So things happened, and 911 got involved, and they worked very efficiently, great communication. And I mean, you guys know that stuff at your baseline, really.
That's pretty typical also for EMS providers. That story that Jerry tells about getting sick and then getting a little bit better. Abscesses are notoriously cyclical. Certainly, if they get out of control, they're going to be constant and patients are going to get crazy sick, crazy fast. But it's not uncommon in the early stages. You guys get called out. Somebody says, "Hey, I had a fever. I was rigering. I was shaking. I haven't been feeling very well. I feel fine right now." Right? That patient certainly could have an abscess brewing.
Yeah, and that was the thing. They'd even hooked me up to the machines and checked my cardiac. They checked everything, and everything was checking out fine again. And then the second time around, it was going south.
Unfortunately, we don't have CT scanners in our medic unit.
Right. Oh my gosh. Yeah, that'd be awesome. I got another great question that I forgot to bring up, and I want to make sure I pull it out. Kindly address gastric tube placement or avoidance thereof post-surgery, and for how long? This is the best question asked. This is super important, super important. If a patient has had weight loss surgery of any kind, do not put in an NG tube, period. Don't do it. So here's the deal. So you might think, well, I want to do that. That's just part of our routine. We decompress the stomach so then we can do an intubation. We don't have to worry about aspiration. I get it. But the problem is that their stomachs are very small. So with the sleeve, again, about the size of a garden hose, with the gastric bypass, about the size of a thumb. And so when you put in a decompressive tube, it's not going to decompress much. There's not much storage. So a before stomach, again, is about the size of a football. You saw me holding it up. That is what needs to be decompressed. So there's not much to decompress, number one. Number two, I have seen it before, patients not telling, maybe they were unresponsive, unable to. They didn't, the EMS or whoever it was, I mean, even, ER doctors, people didn't realize that they had a weight loss procedure. They put an NG tube. I've seen a sleeve get perforated, and I've seen a gastric bypass get perforated. And they could, when it gets perforated, that results in more surgeries and potentially really rough outcomes. So no blind NG tube insertion of any kind on a sleeve or a gastric bypass. So you might see on the medical alert bracelets, some people say like no NG tube, and that's why. And that would be the one thing that would be a number one concern for you guys in the field. That's so good. And so anyway, for how long, especially in the post-op period when it's a fresh anastomosis, but I've seen people years out, if they have an ulcer, you just hit it just right, it was just a thin layer of tissue keeping that in together, you could perforate, more likely with the gastric bypass than with the sleeve, but I have seen it happen years out even after a sleeve. So just be careful on that gastric tube. Do these patients experience any type of depression or mental health complications? I mean, it's a big change, and life changes are tough, and it's, I think, one of the most unused portions of all of medicine is mental health providers, as therapists, and finding one that you really jive with is really difficult. And I think it's a lot different especially for the mind to catch up to the body and the changes physically, and people commenting and then not commenting. You know how it is, no matter if you're a man or a woman, you know that your weight and the way you feel impacts a lot. It's always on your mind. So there could be that, sure. I mean, there's postpartum depression, there's all types of depression and mental health things. So we really want our patients to be able to find a therapist. I think every human should see one personally. What about the high blood pressure and high cholesterol patients? Is this surgery effective? Very. Diabetes is the most effective type of comorbidity that gets resolved, but high blood pressure and high cholesterol, also over 80% will get off of their meds just by losing the weight. So it's not as instantaneous, but it does happen. Are you familiar with health at every size, and how does this mentality interact with your work? I am not familiar with that, but I would love to learn more about health at every size. All right, I'm taking note of this. We got a couple. Wow, Jerry, go Jerry. You're amazing, Jerry. Of course, duh. Can you touch on weight bias with providers? Oh, this is a tough one. And unfortunately exists. You guys might have some weight bias out there watching. Maybe when you guys go to certain houses, you are judging them, their lifestyle, the way they are. Oh my God, they're so fat, they're so lazy. Like, I mean, that's the ultimate F word for me. It's just judging someone having no clue as to what they've gone through or why they're there, and not really thinking, again, like I said earlier, that they don't want to be obese. No one wants to be obese. No one wants to be unhealthy. Everybody wants to live a rich and fulfilled life. And I think sometimes it happens, and it's something that you just try to educate on, and you try so hard to show the struggle and be sensitive and empathetic to these things. But some people, I don't know, they just lose touch of that, and that's a shame. What other post-op care other than nutrition are your patients told to do? Obviously some exercise, but what, anything else? So in the early period, they do have a thin layer of Dermabond, which is skin glue over their incisions. So we tell them to make sure that they just keep them clean and dry. So they can take a shower, they can get them wet even that night. They can immerse them in tubs, or they can even go in a hot tub, or a public pool is fine, actually. So we've done that. Again, soap, water, pat it off. No need for bandages, no need for Band-Aids or lotions or ointments or anything like that. Other things, again, we tell them to move and really just get back to life, like do the core exercises and all that sort of things like you touched on. Is there a maximum age for either procedure? So I do up to age 80 now, as long as you have all of the clearances, and we can safely do this because it is elective, so we have some time to do that. What are the recommendations following surgery for exercise? So I want people to do what they really love. So if you are like, I hate the treadmill, I'm going to do this, you're never going to stick with it, and then you're going to beat yourself up and you're not going to do anything. So does not mean just cardio. In fact, I think the best thing to do is if you can get into high intensity interval training, which is resistance training, weightlifting, doing it in short bursts. I do like 45 seconds on, do another exercise. Getting a trainer maybe might work for you. Just know what you like, your lifestyle. I love the stair climber because I love to read when I'm on there and watch podcasts or watch the master class. I think it's fantastic. So just find anything that you'll like to do and stick with it is perfect. When these patients vomit, is it mostly a dry heave? I assume reduced stomach content would result in less volume, or is it vomiting not a common sign in these patients? It is almost always a dry heave. Bilious vomiting, that's green vomiting of bile or yellow bile after gastric bypass, is an obstruction, period. It's never normal, never normal. In fact, I would almost operate on that patient without even getting a CAT scan or imaging. I know that they're going to have an obstruction, whether it be at the JJ or it might be an internal hernia, which is another longer term complication after the gastric bypass. I make man-made new areas where the intestine can migrate in. I sew those areas in the original operation with permanent suture. It's called Ethibond. But with time, I'm sewing fat to fat, and sometimes in a perfect storm that'll open, intestine gets stuck, incarcerated, can even strangulate. You could have some small intestine vascular compromise. It's a surgical emergency. So if they're vomiting bile after a gastric bypass, it is a potential, it's almost always a surgical emergency, period. Best way to address the mental health aspect from the surgery is knowing you have a group of people behind you and people to talk about it. That is so true. That's why support groups are critical, essential to success. No doubt. Oh, there's the information from me. I'm going to take that down. Perfect. If skin is not elastic, they go to the plastic surgeon. Yes, they can. There are plastic surgeons that take insurance, some that don't. Sometimes it's more cosmetic, sometimes it's more functional. They're getting paniculitis, rashes, boils, different issues between the skin folds from the pannus and that sort of thing. Peripheral access, in my experience, is super difficult in this population. Any tricks of the trade. So you guys are so much better at putting in IVs than me. And that's super true. Sometimes we have to get the IV team under the ultrasound guidance. I don't know if you guys have an ultrasound on your trucks. But that's something that is certainly helpful. I don't know if you have those available to you.
No, unfortunately not.
Yeah, that's the toughest thing. And especially if they're all dehydrated and their veins are puny and then they're morbidly obese and there's lots of tissue, it can be super, super hard, super hard. So I agree, Brian. And then can you speak on alcohol intake after gastric bypass? So we tell patients to avoid it. A couple things: they can get gastritis, they can get ulcerations, and they can also get they can have weight gain. I mean, there's calories and things like that in it. The biggest thing to know is that they get drunk with almost a sip, super fast on buzz, but then a super fast off buzz. And sometimes that can even lead to transfer of addictions downstream, where patients will start to have issues with alcoholism. So it's a big deal. And if you come across a patient that's intoxicated, know that their tolerance with that little stomach pouch and the absorption of the alcohol along the stomach mucosa is going to be fast and furious. So be careful and just treat them like you would anyone that's extremely intoxicated. Boom. What else? Any other questions?
Hey, you guys, don't forget to sign in. Ashley has sent around the sign in the chat a couple of times. Ashley, maybe you could put it again.
There we go. Well, I would love it if you guys all did me one favor. If you are on Instagram, if you would follow me. My name is Dr. Dovec, and that is DRDOVEC, all one word, Dr. Dovec on Instagram. And if you ever have any questions, if you DM me, I will write back. And I would love to connect with you, wish you luck on your journeys, and answer any questions you might have about taking care of this very cool patient population.
Thank you so much. Thanks for your time, and you too. Good luck on your journey.
Thank you so much. Good luck to everyone. This is a cool opportunity. Thank you so much.
Have a good night.
All right, good night, everybody. See ya. Bye.